Who's the first participant? Is she here? Dr. Shreya? Dr. Brinda Ravi? She's absent. Sibilia Karuppa? I think she can start. Yeah, you start. Prevalence of visual impairment and pattern of ocular morbidity in geriatric ward patients. Yes. 5 minutes. Huh?
Good morning to all. Today I'll be presenting my paper on the topic Prevalence of Visual Impairment and Pattern of Ocular Morbidity in Geriatric Ward Patients. These are the table of contents. So, why we conducted such a study? As we all know, elderly people are a valuable resource for any society. But aging is a natural phenomenon with opportunities and challenges. Visual impairment and blindness are strongly associated with aging and late life disability. So, our aim was to estimate the prevalence of visual impairment and pattern of ocular morbidity in geriatric ward patients. So, a hospital based cross sectional study was conducted in the Department of Geriatrics in a tertiary care hospital. 144 eyes of 72 patients were examined, and after taking a detailed history, the visual acuity, anterior segment examination, intraocular pressure, dry eye evaluation, and dilated fundus examination was conducted. 58 subjects were fully cooperative for the complete ocular examination, and all data were statistically analyzed, and a p-value of less than 0.05 were considered to be statistically significant. And based on the visual acuity, visual impairment was categorized into mild, moderate, severe, and blindness categories. And our results were 41.7% were belonging to an age category of 61 to 70, and majority of them were females. 48.6% were having a primary level of education, whereas more than 30% of the people more than 30% of the subjects were having one or more of the comorbidities. More than half, that is 52.8% of them, had not undergone any ocular examination in the past 3 years, and 45.8% were previously involved in an occupation. 43.1% were visited by their relatives once in 3 months. And apart from cataract, these were the other ocular findings which we could see. That is around 73.6% were having tessellated fundus, 51.4% having dry eye, 30.6% having ARMD, and 23.6% having diabetic retinopathy. And we found that prevalence of visual impairment was 79.97%, of them being 41.8% having a moderate level of visual impairment. And cataract was found to be the most common cause of visual impairment in all the categories. The second common cause was found to be age-related macular degeneration in mild, severe visual impairment and in the blindness category of visual impairment. And diabetic retinopathy was found to be the second common cause in moderate visual impairment category. Age had a statistically significant positive correlation with visual impairment. Grade of visual impairment was also higher in more than 70 years of age group. There was a negative correlation between the education status and occupation status with visual impairment, even though the difference was not statistically significant. Visual impairment was found to be less in those having diabetes mellitus and hypertension, but that was not also statistically significant. Coming to the discussion part, in our study, the prevalence of visual impairment was 79.97% and 41.8% was having moderate visual impairment. In the study by Srinivas et al., visual impairment was found to be 30.1% and 23.6% had moderate visual impairment. 43.7% had visual impairment, the study conducted by Mahesh Kumar Dev et al. And in all these studies mentioned above, including our study, cataract was a major causative factor for visual impairment. More than half of the subjects in our study had not undergone any ocular examination in the past 3 years. Study by Mahesh Kumar Dev et al. Found that about 35% of the residents had no history of eye examination during their lifetime. Study by Srinivas et al. Found that compared to those with no formal education, those with school education or higher education had a lower odds of visual impairment, which was similar to our study. In the study of Srinivas et al., those reported to have diabetes and hypertension had lower odds of visual impairment which was similar to our study. Prevalence of dry eye disease and diabetic retinopathy was less compared to our study, and prevalence of ARMD was more in our study compared to the study of Wiba, Florence et al. So to conclude, prevalence of visual impairment was 79.97%, with majority being in the moderate category of visual impairment, and cataract was the most common cause of visual impairment in all these categories. ARMD and diabetic retinopathy was the second common cause. To suggest implementing routine ocular examination in geriatric ward patients and old age homes can help in providing appropriate intervention and treatment at the earliest. Mobile ophthalmology unit and teleophthalmology extending to these subjects can also provide eye care available to the elderly. Educating elderly people and their caregivers can also help in preventing ocular morbidity. Here are my references. Thank you.
Very nice paper, like something relevant in the geriatric population.
Thank
How
you,
will you categorize the visual impairment? How did you categorize the visual impairment as per which criteria?
By ICD 11 criteria, it was categorized based on the visual acuity into mild, moderate, severe, and blindness category. If it is more than,
No, any patient had a glaucoma?
yes, ma'am. But it was only around 2.8%, so it was not
How did you diagnose glaucoma?
based on the intraocular pressure and fundus examination, optic nerve changes. But field was not taken, ma'am.
What was the, like these patients were all in old age homes or in a hospital?
In a hospital, ma'am. In our hospital, 72 patients were there.
So they had come for multiple other causes. Or they had come to ophthalmology, or they were admitted for some other diseases.
Actually, they are like a neglected group of people that have been admitted in our in the geriatric.
So they're
ward as
almost
well.
like it's almost like a care home, isn't it?
Yes,
So
ma'am.
your population is not in the typical, it's a special kind of population,
So,
isn't it? And what is your, what is the criteria for putting them in geriatric age group? Did you have any age criteria?
we took all the patients, ma'am. All the 72 patients were there.
What was the age criteria above which you categorize them as
geriatric?
geriatric?
Yeah, that was 60, above 60 will be in the geriatric group. But here, all the patients were taken, madam. But yeah.
Okay. So there could be a lot of confounding factors. What you said, they had multiple systemic disorders. Did you look at that, whether they were related to their visual impairment?
Yes,
You
ma'am.
said you couldn't find any statistical association.
But diabetes and hypertension, those having diabetes and hypertension were found to be having less visual impairment.
Which is contrary to the
Yeah, but
belief.
this was also found in other studies also, madam.
The study by Srinivas et al., what was the population?
Around 800.
No. Did they do a community-based study, or did they go out into the any particular geriatric home and did it?
Age homes they went.
Okay. So I think, and your your classification of diseases is very varied. It should be more specific. Like you have put Rho plus positivity, Rho plus, all those things as your disease classification. You can probably narrow it down to specific diseases. See, it's expected that with age, your visual impairment increases. What you should try to find out from your study is that in this group of neglected elderly population, is there prevalence of any particular disorder which is more than the group which is having probably a normal community, normal social life? You understand? So normal population, elderly population also have a lot of visual impairment. So in this group of neglected elderly patients, are they having any specific visual impairment? Are there any challenges for them to get care? So those are the things that you should highlight.
All right, ma'am.
Because it is normal that as age increases, visual impairment will happen. Cataract is the most common cause. What you should try to highlight in your study is that, is there any difference in the pattern of visual impairment in this group of neglected elderly population? Are there any challenges for them getting eye care? And if so, what can we do to improve? That should be the thing that you should highlight. Because everybody knows cataract is the most common cause of visual impairment in elderly population. You understand? So that you have to make your paper novel in such a way that it has to be noticed. Otherwise, it just becomes like any survey. So your paper should stand out different from a survey when you pick out a novel feature.
All right, ma'am.
Okay, so that would be the thing that I would expect you to work on it.
Madam,
All the best.
should it be like a comparative study by taking both these subjects?
You have to look at the statistics of a general aging population. It again, cataract will be the highest in them. You compare it with this and see whether there's any difference in the morbidities, ocular morbidity, or if so, what are the challenges which prevent them from accessing healthcare and any other diseases which they are having, which is different from the normal aging
age, ma'am.
population.
Yes, ma'am.
That should be the things.
Yes, ma'am.
Okay.
Thank you, ma'am.
The next speaker, do we give them a certificate? Yeah, I think. Take a picture and send it to her because to encourage them so that they do better next time. And yeah. Do not appreciate it. All the best and try to improve on your paper. Thank you. Yes, yes. Adira, we feel it. Peripheral and posterior fluid changes.
Good morning to all. My paper is on peripheral and posterior pole changes in retina in moderate to high myopes, a retrospective study. Introduction. Myopia or short-sightedness is a frequently occurring ocular disorder affecting worldwide. Can divide into mild, moderate, and severe high myope. In our study, we are dealing with moderate and high myopia patients. Peripheral retinal changes include white without pressure, lattice degeneration, steel tract degeneration, retinal holes, whole should tear, retinal detachment, and posterior pole changes via myopic traction maculopathy, which include foveosis, foveal detachment, macular hole detachment, macular hole with foveosis, macular hole without foveosis, myopic macular epiretinal membrane, and posterior staphyloma, myopic crescent in high myopes. For other posterior pole changes, which include macular changes like choroidal retinal atrophy, constituent tessellated fundus, macular cracks, macular bruise membrane, dome-shaped macula, neovascular myopia maculopathy, which include choroidal neovascular membrane, other peripapillary changes like peripapillary intracorroidal cavitation, myopic conus, pitin conus, and epiretinal membrane vascular microfolds. Aim of our study, which include to evaluate the retinal posterior pole and peripheral retinal changes in moderate high myopia patients. Materials and methods, which we are conducted a retrospective study, 75 moderate high myopia patients who attend the outpatient department of a tertiary eye care center between June 2022 to 2023 were included in our study. All patients underwent comprehensive ophthalmological evaluation, including miscorrected visual acuity, slit lamp microscopy, cycloplegic refraction, lateral fundus examination, OCT, and ophthalmic clinical feature, wide field imaging, and investigations are repeated on follow-up visit, and statistical analysis done using chi-square test, and p-value less than 0.05 we taken as significant. Inclusion criteria include more than 10 years of age and moderate high myopes. Exclusion criteria include myope less than 0.3 diopter, less than -3 diopter, patients with any other retinal pathology. Results were more than about 3/4 of the patients were under 30 years of age group, and we found that above 50% and 50 equal proportion of moderate high myope patients, and peripheral retinal changes were found in 61% of the myope patients. Most high prevalence in white without pressure is the most common finding, and next one is lattice degeneration. Posterior pole changes were only found in 8%. Posterior staphyloma is a more frequent change, and second one is myopic crescent. Peripheral retinal changes were seen almost equal proportion in moderate high myopes. 83% of the posterior pole changes were seen in high myope, and only 17% is seen in moderate myope. While comparing the lattice degeneration, almost half of the patients have lattice degeneration in both groups, slightly high preponderance seen in high myope. There is no significant association seen between lattice degeneration with the moderate or high myopes. Other findings include 3 high myope patients had history of prematurity and there is no evidence of laser treatment in retina. 2 patients had keratoconus and one patient had malformed clinical features and features ectopia lentis. 3 patients had retinal detachment and 2 of the patients are already diagnosed multiple lattice with holes and they are advised barrage laser. They lost follow-up and presentless retinal detachment. Intervention include about 56% of the patients are kept under observation and 40% underwent barrage laser or advised barrage laser, 4% underwent via surgery. Outcome include out of 75-72% face stable visual outcome and who underwent the vitreoretinal surgical intervention. Finally, they had stable attached retina. Discussion include Cheng et al.'s Dani cross-section study in total 120 high myopic individuals and postoperative changes were 2.5% and 61% were peripheral retinal changes. The study showed a significant association between peripheral retinal changes, that is degeneration with the high myopia. Katwani et al. Study prevalence of peripheral retinal changes in myopia patients which include mild, moderate and high myopia. They also showed a significant increase in peripheral retinal changes with the increase in myopia. In our study, we included moderate to high myopic individuals. Peripheral retinal changes were 61%, postopole changes were 8%. We couldn't find any significant association between postopole changes with the high myopia or peripheral retinal changes with the moderate myopia. Conclusion, peripheral retinal changes were found in considerable proportion of subjects with moderate to high myopia. Postopole changes were more seen in hypomyopia. Some of these retinal lesions might predispose to visual impairment. Highly myopic individuals should be educated for the various symptoms like flashes, floaters, and seek care immediately if symptoms arise. As retinal detachment is one of the serious complications of the disease, can compromise vision. Early recognition and treatment is for the predisposing peripheral retinal degeneration breaks is important. Timely intervention can have good visual outcome. These are my references. Thank you.
What's the aim of your study? Why did you do this study?
Uh,
Did you just do it just for the sake of doing the study? I'm just asking you because when you want to do a study, one thing is that it should bring out something little unique, or you must be able to find out something which is already established. You want to confirm it, or you want to find something unique.
Most
See,
of the
what are you? Is there anything in your study which is different from what has been found?
all other studies were usually high myopes on all comparing all other myopes, mild, moderate, high. In my study, we are comparing not included moderate to high myope. Something unique is we couldn't find any association between high myope, postopole changes with high myope or peripheral retinal changes with moderate myope.
Why do you think that is so? Because first of all, your study population is extremely skewed. You are not studying cross-sectional patients. Cross-section means you go out into the population and look at the myopes. You are actually taking myopes who are coming to your hospital. They will come to your hospital because they have a problem, isn't it? Or they have been told they have a problem, isn't it? So there is an extremely skewed population. So that is one drawback. So, and secondly, it's a retrospective study. So, and your population is not randomized, or it is not a cross-sectional study. It is a hospital-based study. So that is one disadvantage. Second thing is your study numbers are too low. What's the number?
75.
That's very low for to know, because if you really want to compare it with the cross-section study, you need to do little more. So first thing is, when you do the study, you can actually do this better. You can sit with your statistician and ask them, because what is the prevalence of myopia in general population? You give the statistics to your statistician and ask the person, how much should be the number that I should do so that I get a statistically significant value. So because myopia is not an uncommon. What is the prevalence of myopia now? And there is a projection now. So by 2050, half of the 1/5 of the world's half of the world's population is going to be myopes. So it's not a joke. And out of that, 1/5 or 25% are going to be high myopes. So your study has a relevance only if your numbers are significant. 75 is too low a number. That is the first thing your study glaringly tells you. So numbers are very important when you're doing a condition which is a very prevalent condition. Okay. So that is something. So if you really want to do the study well, you have to include large numbers. Okay. And you can do hospital based, no problem, but your numbers have to be good. And ideally, it should, if it is a cross sectional study going into the population and doing it, that is good. Okay. And you should compare it with a normal population, then it will be more relevant. Because then you can really say. And in your study, you found that the peripheral retinal degenerative changes were almost similar in moderate myopes to high
High
myopes.
myopes.
Why do you think that is so? Actually, in fact, the peripheral retinal
Peripheral disease
degenerations are
more seen
more
in moderate-
in moderate
moderate
myopes. It is a known fact. And the posterior pole changes
More
will be in high
high
myopes.
myopes.
Okay. So I think you should work on the numbers and see if you can improve on it. Okay. So that would be something. And yeah, this is something because numbers really matters in a condition like myopia.
Okay, thank you.
All the best.
Thank you.
The next presenter. Okay. Yeah, yeah. I mean, that's the best.
Good morning. Today I'll be presenting on the topic comparison of accuracy of intraocular lens power calculation using the two newer formulae in different ranges of axial length. So cataract remains the leading cause of blindness worldwide, and significant advancements have transformed cataract surgery into a refractive procedure rather than a mere extraction. And the accuracy of biometry lies on two key factors like precision and accuracy of the biometric instrument used and the accuracy of the formula employed to predict the effective lens position. And over the years, the intraocular lens power calculation have evolved through a series of formulas, and the newer formulas are Barrett Universal 2 and the Hilabia formula. Antirion and Lenstar are two biometric instruments which employ different technology for biometric measurements, and Antirion utilizes a higher resolution step-soft OCT, whereas Lenstar conducts laser interferometric biometry. So the primary aim of our study was to compare the accuracy of Barrett Universal 2 formula and Hilabia formula in different ranges of axial lengths, and also to determine the agreement between Lenstar and Antirion. So it was a prospective comparative study done in 132 patients, in 44 patients in each group of axial lengths, done between May 2022 to December 2022 in a tertiary care hospital in South India. Patients who underwent uneventful phacoemulsification surgery through a 2.2 mm clear corneal temporal incision with in-the-back implantation of intraocular lens, accuracy of IQ by a single competent surgeon was included in the study. And it was a comprehensive eye examination was done, and the biometry was done using Lenstar and Antirion. IOL power was generated using the two formulae. Phacoemulsification surgery was performed, and the 1-month postoperative refraction was compared with the predicted postoperative error determined by Lenstar and Antirion. And the mean absolute error in the three groups of axial lengths were compared, and agreement analysis between Lenstar and Antirion were also done. Statistical analysis were done, and the results were: out of 132 patients, which is 44 patients in each group of axial lengths, 88 patients were female and 44 patients were male, and the mean age was 68.2 years. And we found there was no statistically significant difference between the actual postoperative refractive error and the postoperative refractive and the refractive error calculated by the two biometric instruments for the two formulas. And the mean absolute error was highest for long eyes compared to short and medium eyes. And Barrett Universal 2 and Hilabia formulae were almost equally accurate for short and medium eyes when measured with Antirion. And Barrett Universal 2 and Hilabia formula had the lowest minimum absolute error for medium eyes when measured with Antirion. And on agreement analysis, there was strong agreement for axial length, average K, Barrett universal to IOL power, Barrett to residual error, and Hill-RBF residual error. And coming to discussion, we compared Barrett universal 2 formula with Hill-RBF formula and did not find any statistically significant difference between the prediction errors between the two formulae. Though it was slightly higher for the long eyes, it was not statistically significant. In similar studies conducted by Roberts et al., Savini et al., and Vaughan et al. Also found similar results. On agreement analysis, we did agreement between Antirion and Lenstar, and we found a strong agreement for axial length, average K, Barrett universal to IOL power, Barrett universal to and Hill-RBF residual error, which is also similar to studies conducted by Kim et al., Fisses et al., and Al-Narawi et al. So to conclude, there was no statistically significant difference between the actual postoperative refractive error and the refractive errors predicted by the two biometric instruments. Both Antirion and Lenstar produced very similar axial length and corneal curvature readings, which are statistically significant. There was a notable difference in the anterior chamber depth measurement between two machines, which may be explained by the Lenstar reading being taken from the corneal epithelium to lens epithelium and Antirion reading from corneal endothelium to lens epithelium. And there was strong agreement between the Antirion and Lenstar for axial length, average K, Barrett universal to IOL power, Barrett 2 and Hill-RBF residual error. Antirion and Lenstar showed weak agreement in measuring white to white Hill-RBF IOL power, and there was no agreement between the two machines in measuring central corneal thickness, anterior chamber depth, and lens thickness. These are my references. Thank you.
The study parameters are all good, like you have categorized them properly. What was your aim in doing this study? Why did you do this study?
The newer formulas, Barrett universal 2 and Hill-RBF, to compare those two formulas and to do the agreement between to know which machine optical biometer is better.
Okay. So which one do you do? What is the routine practice in your hospital?
Lenstar, we do both Antirion and Lenstar.
Okay. When do you prefer anterior? When do you prefer Lenstar? You choose it, or how do you decide which is?
No, for these patients, both Antirion and Lenstar.
Generally?
Generally, we do Lenstar.
Okay. And when will you choose anterior?
For in this study purpose, we have done
You chose
both
anterior. Okay. So what one thing I wanted to know, what was the type of cataract in these patients? That is important. Did you mention that?
We have excluded dense cataracts. Most of the
Have
cataracts.
you included that in your criteria?
Yes,
Exclusion criteria, dense cataracts. Okay. Yeah. And age of the patient.
Age of the patients, those patients in
Were they all senile cataracts,
Senile
or
cataracts.
whether some juvenile pediatric cataracts?
we have
That is
excluded the
important.
pediatric cataract also.
You have excluded. Okay. Okay, fine. So post-operative. This was a retrospective study, yeah? Or
No,
a prospective study? So what was a post-operative BCVA 6/12 or less?
We have excluded those having visual acuity less than 6/12 after the surgery.
So then it becomes a retrospective exclusion criteria.
No, we have done 1 month post-operative refraction. So in that, those having 6/12 vision were excluded.
Why?
Less than 6/12.
Why?
To prevent bias, those having good vision.
You mean to say they had some complications,
Yes,
like edema or something like
yes,
that? Okay, fine. Okay. So there are already a lot of studies which have compared this, and you've got the same results. So what I was more interested is what about the anterior AC depth measurement comparison between these two machines? Because you said your study, you said high axial length eyes were the ones which had the maximum errors, right?
Yes,
Both the machines were
there was
equally
slightly higher values, but that was not statistically significant.
So what would be that parameter which would give the error in the calculation?
Could be the anterior chamber depth measurement between
so
the two.
AC depth is an important factor. So which machine do you think calculates the AC depth better?
Lenstar.
And why do you think so? So probably you should, maybe you should go back and compare some last slide you said you were not able to find any significant difference in the AC depths between the two machines, something like that you
There
wrote.
was a difference between the anterior chamber depth measurement between the two machines because they both employ different techniques for taking the measurement of anterior chamber depth.
Yeah, but before that in the discussion you said there is no notable difference between the two. So they were like two contradictory.
There was a strong agreement for the following parameters, but anterior chamber depth measurement there was no.
So what you can do now is probably you can correlate the anterior chamber depth with the axial length.
Yes, ma'am.
And then see which machine has a better predictive value, because this is all already described.
Yes.
So if you want, suppose which patient will you do selectively anterior or lens star? So if you find that this machine gets a better prediction for higher axial length eyes, because it is, then you may recommend this in higher axial length eyes, isn't it? Otherwise, we are all now transitioned into Barrett's formula, isn't it? For all calculations, we are using, almost all patients we are using Barrett's IOL calculation. So when do you want to recommend, this one formula over the other, or which axial length? That probably you can look into the anterior chamber depth, the lens thickness, and white to white. So probably you need more numbers.
Yes, ma'am.
Because it's such a small number, because cataract is a huge thing, right? So maybe you can work on it. Your study criteria is good. The way you have done it is good. Statistical analysis, all is good. You need more numbers.
Yes.
Okay.
Thank you, ma'am. Thank you.
Good morning. I am here to present my paper on the topic Visual Outcome and Complications Following Retrofixated Iris Glow IOL Implantation in Patients Aged 40 to 80 years in a tertiary center in Northern Kerala. I have no financial interests. So the aim of modern cataract surgery, as we know, is to leave the patient with a good pseudophakia, but in some cases, when things go south, we may have to do an emergency exit and adopt special methods of IOL implantation. So Iris Glow lens is on the rise as a secondary IOL, and compared to its counterparts like anterior chamber IOL, it has a lower risk for endothelial and trabecular meshwork damage, and also compared to scleral fixated IOL, it is technically less challenging and has a shorter learning curve. So the aim of my study was to assess the visual outcome and complications of retrofixated Iris Glow IOL to correct aphakia. So this was a hospital-based retrospective study, and the patients included those who were aged 40 to 80 years who underwent either primary or secondary retrofixated Iris Glow IOL implantation from January 2019 to January 2023. 55 eyes of 55 patients were included. The study setting was Tertiary Health Center in Northern Kerala, and the outcomes were analyzed at postoperative day 1, at 1 week, and at 1 month. So those patients with surgical aphakia with insufficient capsular support, where posterior chamber IOL implantation could not be possible, were included. Patients with any gross iris abnormalities like aniridia or rubeosis iridis, traumatic mydriasis, any other retinal pathologies like diabetic retinopathy, glaucoma, and those with decompensated corneas were excluded. So the preoperative and postoperative assessment included uncorrected and best corrected visual acuity using Snellen's chart, a slit lamp examination, intraocular pressure measurement, fundus evaluation. And all the data were entered in MS Excel sheet and analyzed using an SPSS software. So the results of the study, of the 55 eyes of 55 patients, it was done as a primary procedure in majority of the cases, 85.4%, and as a secondary procedure in 15.6% of the cases, and majority of the patients were of the age group 61 to 70, that is 58.2%. 60% of them were male patients and 40 were female. And the preoperative best corrected visual acuity was 6 by 60 or less in 76.3% of the patients, whereas the postoperative 1 month best corrected visual acuity was more than 6 by 18, 6 by 18 or more in 67.3% of the patients. So according to the WHO classification for visual acuity assessment following cataract surgery, this comes under a good visual outcome. And the mean preoperative IOP was 16.3 plus or minus 3.1 millimeters of mercury, and there was and post-op mean IOP was 17.3 plus or minus 3.2 millimeters of mercury, and there was no significant rise in postoperative IOP noticed compared to preoperative IOP. There were no cases of persistent corneal edema at post-op 1 month assessment. And the most common postoperative complication encountered in my study was iris atrophy, noticed in 13.9% of the eyes, and hyphema was noted in first postoperative day in one eye, which resolved with medical management. There was one eye which had haptic disenclavation, which required a resurgery to do re-enclavation, and 11 eyes had pupillary distortion postoperatively. No major complications including raised IOP, chronic anterior chamber inflammation, bullous keratopathy, cystoid macular edema or retinal complications were noted. So we concluded that the retrofixated iris glow implantation had a good visual outcome and complication profile, and since there were no other ocular comorbidities, it was a direct reflection of lens implantation, and it is a cost-effective method. It provides good visual rehabilitation, has a shorter learning curve, and takes a less surgical time. These are my references. Thank you.
So this was retrofixated iris claw lens, right?
Yes, ma'am.
So what were the parameters that you, pre-operative investigations that you did before you planned an iris claw lens?
Visual acuity, both uncorrected and best corrected, IOP assessment with non-contact tonometry, then anterior chamber anterior segment examination, slit lamp assessment.
How was the AC depth analyzed, anterior chamber examination analyzed?
Anterior chamber slit lamp examination with von Herrich's grading was done.
That was done, okay. So this was, you had two groups, right? Primary surgical aphakia and secondary.
Yes.
So in patient primary, of course, you cannot do, but in secondary aphakia, did you do a gonioscopy? Was an endothelial count done?
No, ma'am.
See,
That
that's
is
the
a
major
drawback.
drawback of
Yes,
your
ma'am.
study,
Yes, ma'am.
because your study follow-up is 1 month, right?
Yes, ma'am.
So that's too short to really know is there any endothelial damage. So that can be probably included, because all these things is okay at 1 month. What happens in the long run with the because iris is extremely inflammation generating tissue. Okay, so we don't know how it is going to react. Huh? So 1 month, and what is the other problem? 1 month you are going to give steroids. Your patients will be on steroids for at least 4 to 6 weeks, isn't it? So once the steroid stops, how is the eye going to behave? That is something that you have to look. So you need a long-term study to know that. And if you can include a specular or an endothelial count in your study, pre and post-op, at least in the group which had secondary aphakia, because in this you're going to do it as a planned procedure. You must know how they behave later. And what was the type of IOL used in your study? Was it the same type of IOL?
Yes, ma'am. Same type
You
of
should mention that, because different IOLs have different types of enclavation, and they have different ways of behavior. So that also makes a big difference. So those things also should be taken into account.
Yeah, I happen to say, I mean, second part of presentation only I saw. Why did you choose iris glow? I mean, what are the other options?
Anterior chamber IOL and then scleral fixated IOL, because with the literature we know this is an easier method which requires less surgical instruments and shorter learning curve and takes less surgical time. So if this can be mastered by the ophthalmic
Anybody, yeah,
surgeons.
okay. So it's basically the feasibility of doing the surgery. Okay. So what was the follow-up?
Follow-up was done at postoperative 1 day, 1 week and 1 month.
So after 1 month, you have not seen the patient. I mean, I'm just asking you. No. Okay.
should be clearly mentioned. Why did you decide? Because it's not a randomized. See, any study becomes very good and comparable if you have another arm which goes for a second option. Like probably if you compare it with SFIOL. SFIOL is the FDA approved standard treatment for surgical aphakia. Okay, Iris Claw is not approved because it is thought to have some long-term complications. But increasingly, we are doing Iris Claw lenses. So if you can prove at least in 6 months that it is stable and good and comparable to SFIOL, then your study is really good. So that could be something else that you could look into it. Okay.
Thank you.
And surgical time. So these things you can compare. Surgical time when you're doing an iris claw lens, it also has a learning curve. So those are the things that you could look into it and try to improve.
Thank you, ma'am.
Good morning. My paper is on comparison of true dry eye questionnaires in assessment of dry eye. Dry eye has a complex and multifactorial etiology. The ocular surface and lacrimal gland are a functional unit that work together to maintain the tear film and ocular surface. In post-LASIK patients, there is decreased corneal sensitivity and blink reflex due to disruption of the corneal nerves, damaged global cells, and altered center corneal surface. So, the post-LASIK dry eye can affect the outcome of procedure. A number of questionnaires were used in assessment of dry eye, which are Dry Eye Questionnaire 5, Symptom Assessment in Dry Eye 2, Ocular Surface Disease Index, Standard Patient Evaluation of Eye Dryness, Contact Lens Dry Eye Questionnaire, McMoney's, etc. Aim of our study was to compare two dry eye questionnaires, SANDE 2 and DUQ 5, in patients who were scheduled to undergo refractive surgeries in our clinic. Materials and methods. Ours was a prospective study, included 106 eyes of 54 patients who were scheduled to undergo three types of refractive surgeries: microkeratome LASIK, femto-assisted LASIK, and transepithelial photorefractive keratectomy for the duration from November 2022 to June 2023. General and ophthalmic history, systemic illness, subjective symptoms were included, and scores were analyzed at preoperatively as baseline and postoperative day 1, postoperative day 1 week, postoperative first month, third month, and 6 months. These are the questionnaires I have used. Dry eye questionnaire 5, which include eye discomfort, eye dryness, and watery eyes. Under the eye discomfort, how often and how intense was the sub-questions, like in eye dryness. And the SANDE 2 questionnaire, which include only 2 questions: frequency of symptoms and severity of symptoms, which range from rarely to all the time, very mild to very severe respectively. Patients on anti-glaucoma medication, patients with previous history of ocular surgery, patients who have non-dry eye were excluded from our study. Result: demographic. Average age was 22.98 years with a range of 19 to 34 years. Sex distribution: 20 males and 60 females in microkeratome procedure, 80 males and females in femtosecond procedure, 22 male and 14 females in trans-PRK procedure. And this is the graph showing mean score measured in each procedure using DEQ5 and SANDE 2 questionnaire. Preoperatively as baseline score taken as 0, and then postoperative day 1, postoperative day 1 week, first month, third month, and 6 months. And red line indicates the procedure trans-PRK, and green one indicates femtosecond procedure, and blue indicates the microkeratome procedure in both graphs. From these graphs, we can understand that in trans-PRK procedure, there is a increase in score in postoperative day 1 in both graphs, and in other two procedures, there is increase in score in postoperative first month, third month, and 6 months. Discussion. Francisco Amparo et al. Have compared SANDE-2 and OSDA questionnaire. It was a clinical-based study conducted in America in 114 patients with dry eye disease, which were also comparable. And Prince et al. Have compared DQ5 and OSDA in a population. It was a population-based cross-sectional study conducted in Ghana, which was also comparable. In our study, we have compared DQ5 and SANDE-2, which was also comparative. And Definies et al. Have compared speed questionnaire and OSDA values. It was a retrospective study conducted in German in 153 patients in a dry eye clinic. It was not comparative because the speed questionnaire was for the evaporative dry eye and OSDI values were for aqueous tear deficient dry eye. Conclusion. Information gained from DUQ5 and SANDE-2 questionnaire was similar. As SANDE-2 questionnaire has only 2 clinical questions, it is an easier practical alternative to DUQ5. These are my references. Thank you.
What was the criteria to choose these 2 questionnaires when there are multiple other questionnaires?
Actually, there was no large study comparing these 2 questions.
So you took
Choose these 2 questionnaires.
Okay. You have taken 3 procedures, no?
Yes.
You have taken 3 procedures. So post-LASIK, at what point of the time you did the study? Like, see, immediately day 1 in the morning, they have lots of problems, irritation, foreign body sensation, etc. So at that time, when you put when you do this questionnaire, was it?
After consulting the consultant. Only.
Okay. So after the, but what was the relevance immediately on day 1? You did the questionnaire on day 1, right?
Yes, ma'am.
Yeah. So what was the relevance? What made you to do the questionnaire on day 1? See, 1 week and 1 month is okay, but day 1. Because we are doing LASIK to improve the vision, not to improve the dry eye. So day 1, what was the relevance?
For the study.
For the study purpose. Yeah, okay. So what's the nerve supply of the cornea?
Ophthalmic division of tribe.
Yeah, that is, I'm specifically asking you what's the nerve supply of the cornea.
Nasociliary.
Then tell me in detail. You are studying about the LASIK, no? Layer by layer. What are the layers of the cornea?
Epithelium, Bowman's membrane, stroma, duas, desmus, and endothelium.
Okay, fine. Thank you.
Thank you.
Good morning, everyone. The topic for my paper presentation is Profile of Strabismus in Thyroid Eye Disease. So thyroid eye disease, we know that it's the most common cause of extraocular muscle enlargement. And here it's autoantibodies, they are directed against the thyroid receptors, which causes the activation of the orbital fibroblast. And this is most commonly seen associated with hypothyroidism, but can also be seen associated with hypo and euthyroid status. As we all know that inferior rectus is the most common muscle affected, followed by medial rectus, and females, they are most commonly affected in more than males, but when males are affected, they tend to have a more severe form of disease. And strabismus in thyroid eye disease, it's due to the inflammation and subsequent fibrosis of extraocular muscles. And smoking is a major risk factor in thyroid eye disease. So CT and MRI orbit, they helps to look for the enlargement of the extraocular muscle bellies. And here we can see that there is enlargement of the extraocular muscle bellies with sparing of the tendon known as the Coca-Cola sign. And MRI orbit, they also help to evaluate the orbital fat expansion. So in the treatment, we have the non-surgical and the surgical modality. Non-surgical, we have the prisms, the botulinum toxin injection, monoocular occlusion, and literature says that around 0.6 to 20% of patients will require strabismus surgery. So the aim of a study was to analyze the profile of strabismus in patients with thyroid eye disease attending a tertiary eye care center who presented with squint or diplopia. And ours is a retrospective study with 28 patients with thyroid eye disease with complaints of squint or diplopia from Jan 2018 to Jan 2023, and patients with other cause of strabismus were excluded. And the data we collected were demographic data, the presenting complaints, complete ocular examination, thyroid status, imaging, systemic diseases the patient had, and the treatment. So out of 28 patients with thyroid eye disease, the age group in our study was from 33 to 88 years, and the most common age group affected was 40 to 60 years, and the mean duration of presentation was approximately 26 months, and in our study, the males were more than the females. And hypothyroidism was the most common thyroid status seen associated in our study, followed by hypothyroidism and euthyroid status. And the vertical squint was the most common type of squint, followed by horizontal. And inferior rectus was the most common muscle affected, followed by medial rectus. And in our study, 24% of the patients had associated lid signs and 36 had proptosis. But we could not do a thyroid antibody test in everyone. Around 25 to 28% patient underwent the antibody test. In that, 29% showed positive results. And diabetes and hypertension was the most common systemic association seen in our study. And 60% of the patients were prescribed prisms, and eventually 8% patient required surgery. So this is one of our patients, a 63-year-old gentleman who was diagnosed with thyroid eye disease, who presented with diplopia, and this patient had left eye hypotropia and also mild elevation limitation, and the patient was given Fresnel prisms, and the patient was doing well with the prisms. This is yet another patient, a 77-year-old with thyroid eye disease, and this patient presented, he had left eye hypertropia and exotropia, and there was also adduction and depression limitation. The patient was not accepting prisms. Eventually, he underwent surgery. Superior rectus recession and lateral rectus recession was done, and on post-op evaluation, the exotropia and the depression limitation was very well corrected, but the patient had only minimal left hypertropia, and the patient is doing well and is under follow-up. And we compared our study with other studies, and most of the studies, the females were more commonly affected, but one of the studies by Millen Naik et al., just like in our study, the males outnumbered the females, and the most common association seen was hypothyroidism. The limitation of a study is the retrospective nature of the study and the small sample size. So the conclusion in our study, vertical restrictive squint was the most common, with inferior rectus the most commonly muscle affected. And what different we found in our study was that males outnumbered the females. These are my references. Thank you.
Thank you. Good presentation. Why do you think males outnumber females in your study?
One reason could be ours is the tertiary eye care center, and also the mean duration of presentation which we saw was 26 months. So probably when they had the intractable symptoms of diplopia and strabismus, they would have presented to our center, and some we had a referred cases. So that could be the reason males were more in our study.
Which are the antibodies you have done in your study?
Thyroid, TSH receptor antibodies and TPO antibodies, but probably because of the high cost, we could not do in everyone. So that is one of the limitations. These were the two antibodies we got positivity.
Thank you.